Download this code from codegive.com, link in the description below. OK, let's dive into a comprehensive tutorial on chronic kidney disease, CKD, pathophysiology, incorporating code examples where relevant to illustrate concepts. This will be a detailed explanation, so prepare for a deep dive. Chronic kidney disease, CKD, a pathophysiological exploration. Introduction. Chronic kidney disease, CKD, is a progressive and irreversible decline in kidney function over a period of months to years. It's characterized by structural and functional abnormalities of the kidneys that lead to impaired ability to filter waste products, maintain fluid and electrolyte balance, and produce hormones. CKD is a significant global health problem, often leading to end-stage renal disease, esrd, requiring dialysis or kidney transplantation. 2. Defining CKD, what constitutes kidney disease? Structural or functional abnormalities. Evidence of kidney damage, even with normal glomerular filtration rate, GFR. Decreased GFR. GFR 60 ml/min/1.73 m superscript 2 for at least 3 months. Markers of kidney damage. 1 or more of the following for at least 3 months. Albuminuria, albumin to creatinine ratio, ACR, greater than or equal to 30 mg/g. Urine sediment abnormalities. Electrolyte and other abnormalities due to tubular disorders. Abnormalities detected by histology, kidney biopsy. Structural abnormalities detected by imaging. 3. Staging CKD. The Kidney Disease, Improving Global Outcomes, KDIGO, guidelines define CKD stages based on GFR. Stage GFR, ml/min/1.73 m superscript 2, description implications. G1 greater than or equal to 90 normal or high GFR, with kidney damage monitor for progression, manage underlying conditions. G2 60 to 89 mildly decreased GFR, with kidney damage monitor for progression, manage underlying conditions. G3A 45 to 59 mildly to moderately decreased GFR monitor for progression, manage complications, example anemia, bone disease. G3B 30 to 44 moderately to severely decreased GFR increased risk of complications, more aggressive management needed. G4 15 to 29 severely decreased GFR prepare for renal replacement therapy, dialysis or transplantation. G5 15, or dialysis, kidney failure, end-stage renal disease, requires renal replacement therapy to sustain life. In addition to GFR, albuminuria is also staged using the categories A1, A2, and A3. A1, ACR 30 mg/g. A2, ACR 3300 mg/g. A3, ACR greater than 300 mg/g. 4. Etiology of CKD. CKD can result from a variety of underlying conditions. The most common causes include diabetes mellitus, diabetic nephropathy. High blood sugar damages the small blood vessels in the kidneys. Hypertension, hypertensive nephrosclerosis. High blood pressure damages the small blood vessels in the kidneys. Glomerulonephritis. Inflammation of the glomeruli, filtering units of the kidneys. Many types exist, each with its own etiology, example IgA nephropathy, focal segmental glomerulosclerosis, FSGS, membranous nephropathy. Polycystic kidney disease, PKD, inherited disorder causing cysts to grow in the kidneys, damaging normal tissue. Obstructions urinary tract obstructions, example kidney stones, enlarged prostate, can lead to back pressure and kidney damage. Reflux nephropathy backflow of urine from the bladder into the kidneys, often due to a congenital defect. Lupus nephritis kidney inflammation caused by systemic lupus erythematosus, SLE. Medications and toxins certain medications, example NSAIDs, some antibiotics and toxins can damage the kidneys. Other conditions less common causes include multiple myeloma, amyloidosis, HIV-associated nephropathy, and sickle cell nephropathy. Pathophysiology of CKD, the mechanisms of renal damage and progression. The pathophysiology of CKD is complex and involves a cascade of events that ultimately lead to nephron loss and progressive kidney dysfunction. Key mechanisms include 1. Initial kidney injury underlying cause the initiating factor, example hyperglycemia in diabetes, high blood pressure in hypertension, immune complex deposition in glomerulonephritis, triggers damage to the kidney structures. Nephron damage this initial injury damages the glomeruli tubules or interstitial tissue of the kidneys. Glomerular damage can lead to increased permeability, allowing protein to leak into the urine, proteinuria. Tubular damage can impair reabsorption and secretion functions. 2. Hyperfiltration and compensatory hypertrophy nephron loss as some nephrons are damaged or destroyed, the remaining healthy nephrons must compensate by filtering more blood, hyperfiltration. Hypertrophy these surviving nephrons enlarge, hypertrophy, to increase their filtration capacity. Short-term benefit, long-term harm initially, hyperfiltration maintains overall GFR, masking the underlying nephron loss. However, hyperfiltration itself is damaging over time. Increased pressure and flow within the glomeruli lead to further injury and sclerosis, scarring. 3. Glomerular sclerosis and tubulointerstitial fibrosis glomerular sclerosis chronic hyperfiltration and other factors lead to sclerosis, scarring, of the glomeruli. The glomerular capillaries become thickened and hardened, reducing their filtration capacity. Tubulointerstitial fibrosis damage to the tubules and the surrounding interstitial tissue, the space between the tubules, leads to fibrosis, scarring. Fibrosis disrupts the normal architecture of the kidney, impairing tubular function and contributing to further nephron loss. Positive feedback loop glomerular sclerosis and tubulointerstitial fibrosis are intertwined and create a positive feedback loop. Glomerular injury leads to proteinuria, which further damages the tubules. Tubular injury releases inflammatory mediators that promote fibrosis in both the glomeruli and the interstitium. 4. Inflammation and oxidative stress inflammatory mediators damaged kidney cells release inflammatory mediators, example cytokines, chemokines. Immune cell activation these mediators attract immune cells, example macrophages, T cells, to the kidney, further amplifying inflammation and contributing to tissue damage. Oxidative stress CKD is associated with increased oxidative stress, an imbalance between the production of reactive oxygen species, ROS, and the body's antioxidant defenses. ROS can damage cell membranes, DNA, and proteins, contributing to kidney injury. 5. Proteinuria and its role in progression proteinuria as a marker of injury proteinuria, excess protein in the urine, is a hallmark of CKD and a strong predictor of disease progression. Asterisk mechanisms of proteinuria-induced damage asterisk. Asterisk tubular toxicity asterisk filtered proteins are reabsorbed by the tubular cells. Excessive protein overload damages these cells. Asterisk inflammation and fibrosis asterisk protein in the tubules triggers the release of inflammatory mediators and promotes tubulointerstitial fibrosis. Asterisk complement activation asterisk proteinuria can activate the complement system, a part of the immune system, leading to further inflammation. 6. Activation of the renin-angiotensin-aldosterone system, RAAS. Asterisk RAAS activation asterisk RAAS is a hormone system that regulates blood pressure and fluid balance. In CKD, RAAS is often inappropriately activated. Asterisk angiotensin II affects asterisk angiotensin II, a key hormone in the RAAS, has several detrimental effects on the kidneys. Asterisk vasoconstriction asterisk angiotensin II constricts the efferent arteriole, the blood vessel exiting the glomerulus, increasing glomerular pressure and hyperfiltration. Asterisk growth factors asterisk it stimulates the release of growth factors that promote glomerular sclerosis and tubulointerstitial fibrosis. Asterisk inflammation asterisk it contributes to inflammation and oxidative stress in the kidneys. Asterisk proteinuria asterisk angiotensin II increases proteinuria. Asterisk aldosterone affects asterisk aldosterone contributes to sodium and water retention, which can exacerbate hypertension and edema. It also promotes inflammation and fibrosis. 7. Endothelial dysfunction asterisk. Asterisk endothelial cells asterisk the endothelium is the inner lining of blood vessels. Endothelial dysfunction occurs when these cells become damaged or impaired in their function. Asterisk impaired vasodilation asterisk damaged endothelial cells produce less nitric oxide, NO, a vasodilator. This leads to impaired vasodilation and increased blood pressure. Asterisk increased inflammation and thrombosis asterisk endothelial dysfunction promotes inflammation and increases the risk of blood clot formation. 8. Metabolic disturbances asterisk. Asterisk phosphate retention asterisk the kidneys play a crucial role in regulating phosphate levels. As kidney function declines, phosphate is retained in the body. High phosphate levels contribute to vascular calcification, hardening of the arteries, and bone disease. Asterisk vitamin D deficiency asterisk the kidneys activate vitamin D. In CKD, vitamin D activation is impaired, leading to vitamin D deficiency. Vitamin D deficiency contributes to bone disease and may worsen cardiovascular disease. Asterisk metabolic acidosis asterisk the kidneys help to maintain acid-base balance. As kidney function declines, the kidneys are less able to excrete acids, leading to metabolic acidosis. Metabolic acidosis can worsen muscle wasting, bone disease, and cardiovascular disease. Asterisk uremic toxins asterisk the kidneys normally excrete waste products called uremic toxins. In CKD, these toxins accumulate in the blood. Uremic toxins contribute to a wide range of symptoms, including fatigue, nausea, vomiting, itching, and cognitive impairment. 9. Cardiovascular disease asterisk. Asterisk increased risk asterisk CKD is a major risk factor for cardiovascular disease, CVD. Patients with CKD have a significantly higher risk of heart attack, stroke, and heart failure. Asterisk mechanisms asterisk several factors contribute to the increased CVD risk in CKD. Asterisk hypertension. Asterisk vascular calcification. Asterisk endothelial dysfunction. Asterisk inflammation. Asterisk anemia. Asterisk left ventricular hypertrophy. 10. Anemia asterisk. Asterisk erythropoietin deficiency asterisk the kidneys produce erythropoietin, EPO, a hormone that stimulates red blood cell production. In CKD, EPO production is reduced, leading to anemia. Iron deficiency. CKD patients often have iron deficiency, which can worsen anemia. Inflammation. Inflammation in CKD can suppress red blood cell production. 6. Illustrative code examples. While we can't perfectly simulate the entire CKD pathophysiology in code, we can model some of the key relationships and feedback loops. These examples are simplified for illustrative purposes. I'll use Python, a common language for data analysis and modeling. Example 1, Modeling GFR decline. This example models GFR decline based on an initial injury and a rate of progression. Explanation. The calculate _GFR function simulates the decline in GFR over time based on an initial GFR and a constant rate of decline. This is a very simplistic model. In reality, GFR decline may not be linear and can be influenced by many factors. Example 2, Modeling the RAAS and blood pressure. This example creates a very simplified model of the relationship between RAAS activity, angiotensin II, and blood pressure. It shows how RAAS inhibition, example with an ACE inhibitor or ARB, can lower blood pressure. Explanation. Calculate blood pressure function models how angiotensin II influences blood pressure, and how RAAS inhibitors would theoretically lower blood pressure. Again, this is a very simplified model. Blood pressure regulation is far more complex, involving multiple systems, example sympathetic nervous system, natriuretic peptides. Angiotensin II levels also fluctuate based on many factors. Example 3, Phosphate retention and PTH. This is a simplified conceptual model of phosphate retention, parathyroid hormone, PTH, secretion, and bone disease. Explanation. The calculate _PTH level function estimates PTH levels based on phosphate levels and kidney function. This model shows how phosphate retention, due to impaired kidney function, stimulates PTH secretion. Chronically elevated PTH leads to secondary hyperparathyroidism and bone disease. This is a highly simplified model. PTH regulation is extremely complex, involving calcium levels, vitamin D, and other factors. Important considerations for code examples. Oversimplification. These code examples are highly simplified representations of complex biological processes. They are intended for illustrative purposes only and should not be used for clinical decision-making. Data. To build more realistic models, you would need extensive data sets on patients with CKD, including GFR, blood pressure, phosphate levels, PTH levels, and other relevant parameters. Machine learning. More sophisticated modeling of CKD progression and outcomes can be achieved using machine learning techniques. These techniques can identify patterns and relationships in complex data sets that may not be apparent with simpler models. 7. Complications of CKD. As CKD progresses, it can lead to a wide range of complications. Cardiovascular disease. The most common cause of death in CKD patients. Anemia. Due to reduced erythropoietin production and iron deficiency. Renal osteodystrophy. Bone disease due to phosphate retention, vitamin D deficiency, and secondary hyperparathyroidism. Metabolic acidosis. Due to impaired acid excretion. Electrolyte imbalances. Including hyperkalemia, high potassium, hyponatremia, low sodium, and hyperphosphatemia, high phosphate. Fluid overload leading to edema, swelling, and hypertension. Uremic syndrome a constellation of symptoms caused by the accumulation of uremic toxins, including fatigue, nausea, vomiting, itching, cognitive impairment, and pericarditis, inflammation of the sac surrounding the heart. Increased susceptibility to infection due to impaired immune function. Malnutrition due to poor appetite, nausea, and vomiting. Neuropathy nerve damage due to uremic toxins. Cognitive impairment due to uremic toxins and cardiovascular disease. Sexual dysfunction due to hormonal imbalances and uremic toxins. Depression CKD can have a significant impact on mental health. 8. Treatment of CKD. The goals of CKD treatment are to slow the progression of kidney disease control blood pressure, ACE inhibitors or ARBs are often used. Control blood sugar in patients with diabetes. Reduce proteinuria. Manage underlying kidney diseases. Lifestyle modifications, diet, exercise, smoking cessation. Manage complications. Treat anemia with erythropoiesis-stimulating agents, ESAs, and iron supplementation. Control phosphate levels with phosphate binders. Supplement vitamin D. Treat metabolic acidosis with sodium bicarbonate. Manage fluid overload with diuretics. Treat hyperkalemia with potassium-lowering medications. Dietary modifications, example low protein, low phosphate, low potassium diets. Prepare for renal replacement therapy, RRT if CKD progresses to esrd, RRT, dialysis or kidney transplantation, is necessary to sustain life. 9. Conclusion. CKD is a complex and progressive disease with significant morbidity and mortality. Understanding the pathophysiology of CKD is essential for developing effective strategies to slow disease progression, manage complications, and improve patient outcomes. The key mechanisms involve a cascade of events, including initial kidney injury, hyperfiltration, glomerular sclerosis, tubulointerstitial fibrosis, inflammation, oxidative stress, RAAS activation, endothelial dysfunction, and metabolic disturbances. While code examples can provide simplified illustrations of some of these processes, it's crucial to recognize the limitations of such models and to rely on comprehensive clinical data and understanding for the diagnosis and management of CKD.